About 2.5 years ago, the board of UICC approved creation of the Global Task Force for Radiotherapy for Cancer Control, trying to address the questions of how can we close the gap in access to radiotherapy around the world. We then worked very hard over 2 years, and just this spring we became the Lancet Oncology Commission on Radiotherapy and produced a report that was published in Lancet Oncology in September this year. Fundamentally, there is a great need for cancer treatment in the world. We all know that there is a great increase in cancer cases around the world projected to occur in the next 20 years, and most of this increase will be in low and middle income countries. These countries really don't have well-functioning health systems and are very ill prepared to face it. And when we talk about cancer control, we usually talk about prevention, tobacco control, vaccination, diagnosis, palliative care, especially in the places with poor health systems. So radiotherapy never comes up as a priority to talk about, and that's why the task force. Because, for example, in Africa, there are at least 30 countries with zero access to radiotherapy, and some countries that have access have 2 to 3 machines for populations of 40 to 60 million people with a 2-year waiting list, which is basically translated as no access for the population, and radiotherapy being used only for palliation. The palliative role of radiotherapy is very, very important, but it doesn't extend survival and doesn't save lives. So what the task force concentrated on is the use of radiotherapy to actually contribute to the cure of cancer and extend survival and save lives. So what we did, we calculated how much would it take to close the gap in access throughout the world, both in low-income countries, middle-income countries, and high-income countries by 2035. And the reason for the 20-year time period is because it takes time. It takes time to scale up radiotherapy, to build the new facilities, to train the workforce, and to implement the program. So it's unrealistic to do it faster than that. However, we know that the number of new cancer cases by 2035 will be much more than now. It will be over 24 million new cancer cases. So we calculated this gap up until 2035. It is well known what the benefit of radiotherapy in cancer is. There are a number of studies suggesting that on average, about 50% of patients who are diagnosed with cancer will benefit from radiotherapy. So what we did is we calculated the number of years life saved with radiotherapy for top 10 cancers in the world. So top 10 cancers in frequency where radiotherapy is used. Even though in liver cancer it's not used, we took it into account. And we then calculated what would be the survival, 5-year survival of patients without radiotherapy, treated without radiotherapy with other modalities, and with radiotherapy. And by calculating this gap, we could actually calculate the number of years life saved if you had equitable access to radiotherapy around the world. And that number was very, very high. We've calculated that by 2035, there will be at least 27 million life years saved if you had good access to radiotherapy. And then we calculate how much would it cost to scale up. We obviously use the numbers, average cost of equipment, average cost of building the facility, cost of training people up until 2035. And we actually concluded that for the whole world it will be $184 billion. That's to scale up by 2035. And that cost in low-income countries, however, would be only $26.6 billion, which, considering it's a 20-year time frame, is not an insurmountable number. And then we went further, and using well-accepted investment framework calculations, the same calculations that were done to look at the cost-benefit of treatment of HIV, malaria, TB, and other diseases, we calculated if we saved lives and if people remained active and contributed to the workforce, or just being alive, contributing to society, what would be the economic return on investment? And we were pleasantly surprised that this economic benefit was actually quite large, and it amounted to about $100 billion if you use the efficiency model. So we first of all calculated the nominal model where we use the equipment 12 hours a day. We replace equipment every 12 years. We produce staffing ratios and practices that are common in high-income countries. We then said, if you did mass purchase of equipment, if you operated the equipment longer, if you replaced the equipment less frequently, if you were more efficient with the use of equipment, what would be that benefit? And that benefit and that return on investment is usually much greater. And we think that the efficiency model is quite feasible, especially in low-income countries. It was very interesting to know that when you looked at the cost of setting up the radiotherapy equipment, in high-income countries, most of the cost is human resources. In low-income countries, as you could expect, is cost of equipment. So if we can lower the cost of equipment, considering that the human resources are much less expensive, operating costs are much less expensive in low-income countries, scaling up radiotherapy is quite feasible. Yes, this is becoming more and more the tenet of looking at healthcare. You know, in our countries, healthcare is looked always as an expense. All the ministries say that the health ministry should spend less money, we should spend less money on healthcare, but nobody up until now actually looked at the economic benefits of people living longer. And it's quite, I think it's been found that improving the life expectancy in population actually produces the benefit in terms of national GDP. So healthy countries become wealthy countries. And that could be probably translated for individual diseases and individual interventions. Obviously, there are many assumptions that you make along the way. You make assumption about quality of care, you make assumption about utilization. We know, for example, that although the optimal utilization, calculated utilization for radiotherapy may be 50%, in some high-income countries it's about 35 or 29. So I think that you look at an ideal model and you calculate benefit, knowing that probably you're going to achieve 80% and less of this benefit. I think that data can be used by WHO, by governments, by industry. It's really a motivation to lower the cost of equipment and treatment and to push for starting to close the gap. Because by many countries, radiotherapy is considered to be something too complicated, too expensive, too difficult to set up, so people sort of set up treatments for cancer and eliminate radiotherapy as one of the elements of treatment. What we've tried to show that it's not only beneficial in terms of saving lives, but it's also affordable in the long term, but it does need an initial outlay of funds and money to establish the facilities, because unlike some other aspects of healthcare, without the treatment facility of machine, you just can't do it. And therefore, setting up the centers with equipment is very important. The other important thing that we found is that it will require a huge increase in human resources, in trained people. The radiotherapy does require a multi-professional approach. We need radiation oncologists, cancer specialists who know how to use radiotherapy. We need medical physicists. In many countries, medical physics is not an accepted health profession, and we need to change that parameter to say they are a health profession, medical physicists. And then radiation technologists. So absolutely thousands and thousands of experts need to be trained. And it's also a call to action by universities, to professional organizations to scale up the education efforts and also simplify the education efforts. Medical education right now has a very old system. There are barriers in credentialing, there are barriers in how many years it takes to produce an expert, but there are some initial efforts to do competency-based education where you can just learn what you need to do and enter the workforce much earlier than in high-income countries. So there are many challenges, and we made suggestions in the report of how to overcome these challenges. Probably a combination of online and practical, combination of partnerships, combination of short-term exchanges, combinations of people from low-income countries going to middle-income countries, but also vice versa, reverse learning, and basically new models of collaboration and teaching. We've put up a call to action. One specific call to action that we've put out is it's very difficult to scale up radiotherapy everywhere all at the same time. We believe that each country should have a cancer center of excellence with radiotherapy. Clearly, radiotherapy is only part of treatment of cancer. In order for radiotherapy to be effective, you need to have accurate cancer diagnosis. You need to have assessment of extent of disease with imaging, and you need to have surgery and chemotherapy because most of patients with cancer these days do require multimodality effort. So although our report talks about radiotherapy, we do recognize that the environment and the ecosystem for radiotherapy needs to have all the other elements of cancer present in order for radiotherapy to achieve its benefit. It also needs to have ecosystem that has adequate power supply, adequate facilities, transportation, and other non-medical elements to produce the desired effects.